So good afternoon everyone. So I will be speaking on acute pancreatitis. So we'll be discussing how to diagnose pancreatitis and how to manage acute pancreatitis in critical care setting. So we'll start with the case presentation. So this is a case of 45-year man presented with severe epigastric pain and vomiting of 10-hour duration, symptoms that had developed after binge alcohol intake previous night. He is also ethanolic since last 10 years. On examination, he is tachycardic, tachypneic, febrile and BP is around 100/70. And he is also complaining of moderate epigastric tenderness without peritoneal sign. On examination, there is TLC 16,000, hematocrit of 40%, and he is also complaining of pain radiating to the back. So, what is the cause of epigastric pain? What are the causes of epigastric pain? So, that could be because of acute cholecystitis, can be because of peptic ulcer disease, aortic aneurysm, dissection of aorta, it could be because of the mesenteric ischemia. Okay, as we are discussing pancreatitis, so this is a case of acute pancreatitis. So what is important in history and examination? So time of onset of pain, it is important to calculate the week of pancreatitis as the treatment plan may be formulated. And one should also ask for the past history of similar kind of pain to differentiate between the acute pancreatitis or chronic pancreatitis, or to differentiate between the recurrent pancreatitis. And one should also ask for the history of alcohol and drug history if the patient is taking any medication to rule out the etiology of pancreatitis. On physical examination, there will be a decreased air entry at the base. So you will see a baby lung. So what happened in pancreatitis? Because of inflammation of pancreas, there will be a raised diaphragm and there will be a splinting. And because of splinting, patients may have respiratory distress, and sometimes you will see the patient may present with extrapancreatic infections like pneumonia, or there may be a because of pancreatitis there may be a effusion or basal atelectasis. So these type of patients may have respiratory distress, and these patients may require some sort of respiratory support. Okay, so they may require HFNC support, high flow nasal cannula, or require NIV support just to decrease the work of breathing. Okay, but we do not prefer non-invasive ventilatory support, because in this patient what happened, because they are already having abdominal pain, they will not tolerate non-invasive ventilator support. So HFNC is a good modality and can be used in such scenario. And we also need to look for tense abdomen, whether the bowel sound is absent or sluggish. So is there any specific biochemical marker would you like to set? So amylase and lipase level should be sent. Along with this, you need to set CBC, RFT, LFT, coagulation profile, and electrolyte like calcium and magnesium. So why calcium? So most of the patient, what happen in pancreatitis, you will find hypocalcemia. But if there is hypercalcemia, then it is suggestive of you are dealing with hypercalcemia induced pancreatitis. Okay, so one should also look for triglyceride level. Okay, so if it is triglyceride level, if it is more than 1000, that indicate you are dealing with hypertriglyceridemia induced pancreatitis. So ultrasound is not very sensitive for detection of pancreas, because most of the time you will find the pancreas is most of the time it is obscured by the bowel gases. Okay, so ultrasound is very sensitive for detection of gallstone. Okay, and its sensitivity around 95%, but it is less sensitive for detection of CBD stone, and its sensitivity around 30%. Okay, so as per the guideline, ultrasound should be done in all the patients with the suspected pancreatitis to look for gallstone. And chest x-ray should be done to look for causes of respiratory distress. So we need to know whether your patient is having pleural effusion, atelectasis, or extrapancreatic infection. Okay, so x-ray, chest x-ray should be done, and CRP and procalcitonin inflammatory marker should be done to rule out the infective etiology. Okay, and ABG should be done to look for PO2 and FiO2 ratio. So once you have sent some investigation, so you are also expect result out of it. So hemo concentration. So what happened to hematocrit? So hematocrit will be high in acute pancreatitis. Why? Because of the volume sequestration, because of the third spacing and capillary leak, you will have hemo concentration, and ALT is more than 150, that indicate gallstone induced pancreatitis, and CRP is a very good prognostic marker. So if it is more than 150, that indicate you are dealing with severe acute pancreatitis. If, as I said before, triglyceride, if it is more than 1000, that indicate hypertriglyceridemia induced pancreatitis. So as I said earlier, ultrasound is not very sensitive for detection of pancreas, but can be used to detect gallstone, cholecystitis, biliary tree obstruction, free peritoneal fluid, and dilatation of common bile duct. So how will you diagnose? So basically, serum lipase, you all know serum lipase is a gold standard for detection of acute pancreatitis, and that rises in 4 to 8 hours, and that remains in the blood for 7 to 14 days, and it is more specific than the amylase. And especially what happen in alcohol pancreatitis, lipase is more sensitive than amylase after the 48 to 72 hours. So utility of lipase over the amylase is greater in patients who present late to you. So the level of lipase does not correlate with the severity of pancreatitis. So doing lipase on daily basis, it is not indicated, and it is not related to the severity of disease. So next is amylase. So amylase rises within the hour and return to a normal in 3 to 5 days, and in 20% of the patients may remain within the normal range. So in alcohol induced pancreatitis and hypertriglyceridemia, it can be remain in normal range. In the certain condition that falsely elevated amylase level, like microamylasemia, DKA, decreased GFR, disease of salivary gland, or extrapancreatic abdominal disease like acute appendicitis, cholecystitis, intestinal obstruction, or ischemia, you will have falsely elevated amylase level. So after the diagnosis, we should also look for the etiology. So what are the most common etiology for acute pancreatitis? So gallstone and alcohol both are the most common causes of pancreatitis. Other are the hypertriglyceridemia, drug like azathioprine, furosemide, AC inhibitor, valproate, erythromycin. These are the common drugs that can causes acute pancreatitis. So ERCP, post-ERCP pancreatitis is also common, but 5 to 10%. But studies they have suggest that use of rectal endomethacin before doing ERCP, that can reduces the incidence of ERCP induced pancreatitis. Infections like CMV, EBV, and mumps, that are also common but less than 1%, and trauma and hypercalcemia, the incidence are very less than 1%. Okay. So how do you diagnose? So basically, as per Atlanta classification that published in 2012, two of the following 3 criteria should be required for diagnosis of pancreatitis. So characteristic of abdominal pain. So patients may present with persistent, severe, acute onset abdominal pain, and that is radiating to back and relieved by bending forward. Okay. And serum amylase and lipase 3 times greater than the upper limit of normal. And third is characteristic finding on CCT abdomen or less commonly on MRI on and USG abdomen. So they have classified into 2 phases: early phases, that is last less than 1 week, and late phases that develop after 1 week. And severity is classified as a mild, moderate, and severe. So mild cases, there is no organ dysfunction. In moderate cases, organ failure less than 48 hours. It also got transient organ failure. Okay, so it relieved, it recovered within the 1 week of treatment. And the mild and moderate cases can be managed in high dependence unit. And severe cases, it is classified as an organ failure longer than 48 hours after the adequate fluid resuscitation. Okay, these group of patients may require intensive care monitoring. Okay, so this is a severe group, and in this patient is having organ dysfunction, and that is persistent, that is last for 48 hours after the adequate fluid restriction, and patient require ICU admission. And there are two types, edematous pancreatitis and necrotizing pancreatitis. Okay. So is there any role of CT scan for a diagnosis of pancreatitis? No. So basically when your diagnosis is not clear, okay, so CCT and MRI of pancreas should be reserved for patients in whom the diagnosis is not clear. Okay, and when you are suspecting local complications of pancreatitis, local complication of pancreatitis like necrosis, any fluid collection or peritonitis, or so in that condition you can go for CT scan. Okay, but it should not be done within the 1 week of pancreatitis, because within the 1 week if you do, then there will be no collection or no necrosis. Okay, so it should be done after the 1 week of pancreatitis. Okay, and if you are suspected any infected necrosis, then CT guided FNAC should be done, and gram stain and culture should be sent for further evaluation. And if your patient is initially he is okay, but after the initial management, if your patient is deteriorating, then you can consider CT scan for to look for any necrosis, any collection. Okay, so is there any role of MRI? So MRI is also reserved for certain condition like young patient, for pregnant patient, and if the patient is having contrast allergy, then MRI should be considered. So magnetic resonance cholangiopancreatography should be done to identify the CVD stone and to delineating the pancreatic and the biliary tract anatomy. So sensitivity is around 95 to 97% for biliary obstruction, and it is indicated when you find elevation in liver enzyme with non-visualization of the stone or normal CVD on ultrasound. Okay. So this is a Balthazar CT severity grading. So this is basically we are doing to look for the pancreas status, and we do a contrast enhanced CT scan to look for the necrosis status. Okay. So they have given 4 scoring system. So basically normal they have grade 0. If there is a focal or the diffuse enlargement, they have graded 1, and if focal and diffuse enlargement with the plus peripancreatic haziness is there, so they have given grade of 2, and if the grade of B, C plus 1 ill-defined fluid collection is there, then the score is 3, and B, C plus 2 ill-defined fluid collection is there, the score is 4. Okay, and for contrast in the enhanced CT scan score, so if there is no necrosis, they have score as a 0, and if less than 30% necrosis there, then score is 2, 30 to 50% score is 4, and if it is necrosis more than 50%, the score is 6. So score of more than 7, that indicate greater severity. Okay. So there are many fancy scoring systems available to predict the severity of pancreatitis. Okay, but this is a biceps score. This is basically most accurate and can be done easily in clinical practice, can be done at the bedside of the patient, and there are 5 variables. So burn, if burn is more than 25 milligram per deciliter, and impaired, if the impaired mental status is there, if the patient has abnormal mental status with the Glasgow Coma score of less than 15, if the SIRS, if there is evidence of SIRS, and if the patient age is more than 60 years, and if there is a pleural effusion on imaging study, so if the score of 0 to 2 point, there will be a lower mortality less than 2%. And if the point is 3 to 5 point is there, there will be a higher mortality, and it is more than 15%. Okay, so this biceps score is most accurate, can be done at the bedside of the patient. Okay, and easily applicable. So other scoring system are the Apache 2 at the time of admission and at the 48 hours, Ranson score, modified Glasgow score, CRP, but it has a low sensitivity and specificity as compared to biceps score, and also it has a positive predictive value that is less than 50%. Okay, so it is not validated as compared to biceps score. So is there any practical way to assess the severity of pancreatitis? So we do a CRP as per the guideline. They have suggested CRP should be done at the time of admission and daily for next 72 hours. Second, you can do a Apache scoring if it is more than 8 or higher, and it should be calculated at the time of admission and daily for next 72 hours. And if persistent organ failure for more than 48 hours despite the adequate fluid resuscitation. So with these three criteria we can also assess the severity of pancreatitis at the bedside of our patient. Okay, so how do you assess the organ failure? So as per the modified Marshall score, we can assess the organ failure. For respiratory system, we have to do a PO2 FiO2 ratio. For renal failure, you need to do a serum creatinine, and for cardiovascular, you need to look for the systolic BP of your patient. Okay. So what are the local complications that is associated with the pancreatitis? So acute peripancreatic fluid collection, pancreatic pseudosis that develop after the 4th week of pancreatitis, acute necrotic collections, and Waldorf necrosis that develop after the 6 weeks of pancreatitis. So this flowchart shows type and prognosis of pancreatitis. So acute pancreatitis, that is divided into the interstitial pancreatitis and necrotizing pancreatitis. So interstitial pancreatitis, 80 to 85% cases have interstitial pancreatitis, and they have moderately severe acute pancreatitis. It is also called transient organ failure, and the mortality is less than 2%. And necrotizing pancreatitis, the 15 to 20% of the cases have necrotizing pancreatitis, and they divided into the moderately severe acute pancreatitis. Mortality is less. It's also called transient organ failure. So the moderately severe acute pancreatitis can be managed in high dependence unit, and that is recovered within the 1 week of treatment. And if the severe acute pancreatitis, the mortality is high, 15 to 35%. In this case, the patient may persist with the organ dysfunction, and that is last for 48 hours after the fluid resuscitation, and this group of patients will require intensive care monitoring. And they further divide into the sterile necrosis. Mortality is less, but if it is infected, the mortality is high, it is 30%. It is also called critical acute pancreatitis. Okay. The lower panel that suggests the duration of pancreatitis. Okay. So who is at a risk? So the patients who have a pre-morbid characteristic like age is more than 55 years, if obesity is there, if BMI of more than 30 and comorbid condition is there, heavy alcohol intake is there, if there is a persistent surge after the 48 hour of fluid resuscitation with the high CRP and inflammatory marker are high, if the persistent elevated burn, creatinine and hematocrit even after the adequate fluid resuscitation, and if there is a radiological finding of pleural effusion, pulmonary infiltrate or multiple or extensive extrapancreatic collection is there. So these are the risk factors you need to consider while treating pancreatitis. So how do you manage pancreatitis? So first and foremost thing is to give fluid. So early aggressive fluid resuscitation is the key to manage pancreatitis. So most beneficial in first 12 to 24 hours. So which fluid to be given and at what rate? So fluid should be given at a rate of 5 to 10 ml per kilogram per hour, and you should do a cardiopulmonary monitoring. So if your patient is having any underlying heart condition, you should do a cardiopulmonary monitoring. And what is your end point of fluid management? So the hematocrit and burn should be fall after the fluid resuscitation. So which fluid to be given? So isotonic balanced crystalloid solution should be used. RL may be preferred. So they did multi-center randomized control trial of 40 patients, and one group were treated with the ringer lactate and one group treated with the normal saline, and they did find significant decrease in SIRS as well as CRP level in RL group at 24 hours. But ringer lactate should not be used when you are treating hypercalcemia induced pancreatitis. Okay. So fluid requirement should be reassessed at frequent interval in first 6 hours of admission and for next 24 to 48 hours. So if you give fluid more than this period, it will not benefit to your patient. So what happens? There will be a leaky capillaries, there will be a third spacing, and fluid sequestration will be there, and patient may end up into volume overload. So you need to be very careful while giving fluid beyond these hours. Okay, and you should not forget the risk of volume overload, raised intra-abdominal pressure, AKI, ARDS, and brain edema. So fluid resuscitation only be done for patients who need it, and once you start enteral feeding, cut down your maintenance fluid, and after your resuscitation phase is completed, and re-resuscitations once patient is clinically stable. Okay, so you need to frequently reassess for fluid management in such scenario. So how will you do of pain relief? So patient controlled analgesia should be used, or opioid acetaminophen should be used, or you can consider epidural analgesia that can reduce the systemic opioid use, and that can also improve the bowel motility and facilitate the enteral nutrition. Okay, and it also improve the pulmonary function, and it also relieve the patient pain, and also give comfort to your patient. So how will you give feed to your patient? So basically for mild pancreatitis, you need to start on low fat oral diet as soon as the severe pain, nausea, vomiting and ileus has settled. So how do you feed in severe pancreatitis patient? So no advantage of artificial tube feeding in less than 24 hours. Attempt oral feeding at 72 hours. So consider tube feeding in 2 to 3 days if the oral feeding is not tolerated, and there is no difference between NJ or NG. So both are comparable, both are same efficacy. So if your patient has a high gastric output, if the patient has gastroparesis not tolerating nasogastric tube feeding, then you can consider nasojejunal tube feeding. So parenteral nutrition only when enteral route is not available or not tolerated or not meeting your caloric goals. Then you can consider parenteral nutrition. Timing of enteral nutrition. So they did multi-center randomized control trial in 208 patients in severe acute pancreatitis, and they found that they did not find any difference in primary outcome, and 69% of demand group tolerated oral feeding when started after the 72 hours. So how do you manage infection? So is there any role of prophylactic antibiotic in while treating pancreatitis? No. So antibiotic prophylaxis only recommended following the endoscopic sphincterectomy. And the studies, they have shown that with the use of prophylactic antibiotic, that is associated with Clostridium difficile, colitis, MDR infection, and that is also associated with the fungal infection. Okay, so up to 25% of the infection is documented in the first week. Okay, and if your patient is ICU on ventilator and on lines and tube, you should not forget the extra pancreatic infection. If your patient is having fever, it could be because of the pancreatitis, but if your patient is having still fever, that you can consider VAP or COTI or CLEPSI if your patient is on ventilator or on lines and tubes. Okay. So if your patient is not stable after the 7 to 10 days and there is a recurrent sign of SIRS is there, then you can consider CT scan. So on CT scan, if there is a gas bubble is present, so that indicate infected necrosis. So in that condition, you should go for CT or USG guided FNA, and gram stain and culture should be done. So if the gram stain is positive, then you need to start antibiotic as per the gram stain report. So empiric therapy only in unstable patient. So which antibiotic should be used in pancreatitis? So cephalosporin, metronidazole, fluoroquinolones, carbapenems have excellent pancreatic penetration. So these group of antibiotic can be considered. So what is role of ERCP? So ERCP is not a diagnostic tool. It should not be used as a diagnostic tool. It should be done within the 24-hour in a case of gallstone pancreatitis with the evidence of cholangitis and biliary obstruction. And endoscopic ultrasonography, it is more sensitive as compared to the ultrasonography for detection of cholelithasis and for minimum invasive treatment of the pancreatic pseudocyst or Waldorf necrosis, pancreatic necrosis. So endoscopic ultrasonography can be considered for drainage of pseudocyst, and you are planning to do a drainage of your wall of pancreatic necrosis. Okay. So is there any role of surgery? So as per the study, they have suggested that percutaneous drainage and minimal invasive technique is preferred as compared to open necrosectomy. So open necrosectomy to be delayed for last 4 weeks. And if you are suspecting any retroperitoneal hemorrhage or peritonitis or abdominal compartment syndrome, when percutaneous or other drainage technique not successful, then you can consider surgical approach. Okay, otherwise minimal invasive technique or ultrasound guided percutaneous drainage is preferred while you are planning to drain the necrosis. So this is study published in NEJM. They have looked at a step-up approach or open necrosectomy for necrotizing pancreatitis, and they concluded minimal invasive step-up approach as compared with the open necrosectomy reduces the rate of composite endpoint of major complication and death among the patients with the necrotizing pancreatitis and infected necrotic tissue. Okay, so it's always better the minimum invasive step-up approach. This is the same study. So how will you treat biliary pancreatitis? So urgent ERCP or sphincterectomy for cholangitis or the biliary obstruction. So percutaneous transhepatic gallbladder drainage if ERCP is not feasible. And cholecystectomy is not done, then up to 18% of the risk of recurrence of biliary pancreatitis if discharged without cholecystectomy. So before discharge from hospital, reduces the subsequent gallstone related complications by 75%, and ERCP sphincterectomy if cholecystectomy not feasible. Okay. So this is this flowchart that shows how to treat pancreatic necrosis. So when you are suspecting infected necrosis, then CT guided FNAs should be done, and gram stain should be sent. So if the gram stain or culture is negative, then consider sterile necrosis. Then you need to continue your supportive care. Consider repeat FNA every 5 to 7 days if clinically indicated. If your patient is clinically stable, then you should consider continue antibiotic and observe. Delayed minimal invasive surgical endoscopy and radiologic debridement. If your patient is asymptomatic, consider no debridement. If positive gram stain or culture is there, then consider infected necrosis. If your patient is clinically unstable, then prompt surgical debridement is required. So this is a flow chart. Okay, so this is summary of management. So after 48 to 72 hour admission, you should make diagnosis. Fluid resuscitation should be done within the 12 to 24 hours. So beyond this time, there will be a fluid overload. Okay, so always you need to reassess the fluid status of your patient. Pain relief should be obtained. Nutrition support should be started once your resuscitation phase is completed. pain relief should be achieved, and start as early as you need to start oral feed. If your patient is not tolerating, start enteral nutrition, and if your patient is not tolerating oral or enteral, then you can consider parenteral nutrition. So first you need to optimize the perfusion of all the organ supports should be done. If your patient is requiring mechanical ventilation, if your patient is tiring on NIV or HFNC and not able to clear the secretion, you should consider the mechanical ventilator support, and if endoscopy therapy if needed, it should be done. And surgical intervention only for local complications, minimal invasive approach should be done whenever possible. Antimicrobial therapy only for proven infection or unstable patients with the suspected infection. So half of all the death occur in first 2 weeks, that mainly due to the multi-organ dysfunction, and half of death occur after the first 2 weeks is mainly because of the pancreatic and extrapancreatic infections. Okay. Thank you. Any questions? No question.